Very good evening and welcome to all of my beloved colleagues today to our session with my humble introduction with the Institute and the Moral Alert. We're going to the topics of today is the investigation, planning and interpretation. Uh, Today we may not be homogeneous gathering as the topic is too much important. This topic is not only important for the exam, though we will target the exam as a priority, but in our day-to-day practice, everybody should know about it. And just before going to the detailed explanation, if I show you one slide, please, can you see the slide? Can you let me know, please? Can you see the slide? Anyone, doctor? Hopefully you can see the slide, please. Hello?
Osman, yes, visible.
Yeah, visible. So thank you very much. This slide as shown, it is an actually geriatric slide for the investigation and further evaluation. My question is, do we go for all the investigation here in this case or in such a patient? What you are thinking? What is the possibility? Are we going to do all the investigation for any delirium patient? Dr. Javed, please, if you can respond. And most likely no. Most likely no. That means we consider the clinical condition of the patient. A patient presented with the delirium, if we suspect infection, then only we do this test. So suspicion of infection is skill. It is our quality. If I don't have this capability, if I just recall from the book, we have all intention to do all investigations. So it is valueless. It's like being a foolish. So today in our general discussion, we will try to highlight you the common investigations in our day-to-day life, as well as we will give you some tasks today. Especially I request all the OSCE candidate, especially OSCE candidate, though it will be useful for everyone to be connected very deeply with us, because in between the discussion, we will give you your task that you will make an investigation plan after discussion of a patient. So I hope and believe that you actually will be in this cooperation with us. Okay. So what are the common investigation? If you like to say, these are the common investigation. If you look at there, some general investigation, some specific investigation. But what is the meaning of general if we say, may I request Dr. Javed, please, can just to interact with me,
Sure.
Dr. Javed. We are telling that these are general investigation, these are specific investigation. Why we are telling a specific investigation?
Specific for you, if you have something special, specific disease in the mind, for
Yes,
that specific, like sickle cell, celiac disease, you
right,
do.
right, right.
So revenue is general is for
Yeah.
almost everything, for every thing.
Yes, if we say the liver function test, we are targeting the liver disease. Okay. But by CBC or FBC, whatever we say, what organ we are targeting, Dr. Javed?
CBC anemia, or even
Okay, we are trying to
general,
diagnose
general.
anemia,
It's not
but target organ. Always in the disease process, we have to think where is the disease, then what is the disease? Where is the disease and what is the disease? So if we start with the CBC, where is the disease we are targeting?
Infection, anemia. I mean,
Could
something.
be, could be. So CBC means many things, right?
Yes,
For
yes, sir.
example, if I come to the liver function test as ALT. So where is the disease we are targeting?
Liver.
Liver. But in CBC, if we remember the points of CBC we are checking, it is not directly meaning any organ-specific disease or abnormalities. If we say CBC indicating which type of disease, we cannot say specific. But if in the liver function test, for example, if we check ALT and it is very, very high, most likely cause is hepatitis, right? Enzyme is 300, 400. This is the hepatocellular damage is there. But if we say hemoglobin is low, where is the disease? We cannot say. Hemoglobin is low due to many, many causes. So the disease anywhere in the body is reflected in some investigation. Those are called general investigation. But again, it is not very, very absolute distinction. Dr. Javed, if I see that in the CBC, hemoglobin low, WBC low, platelet also low, where is the possible location of the disease?
Pancytopenia, that means maybe is bone marrow.
Bone marrow. So in this way, we can have some idea of location of the disease also. Okay. Again, if we say in the CBC and patient presented with deep vein thrombosis, in the CBC we are getting polycythemia. Can it say some etiology of the DVT? As cause of DVT is polycythemia, high hemoglobin. Can we say yes? It can explain that polycythemia causing DVT. So these are written in the text anywhere, just to give you some idea that the single investigation is not very absolute meaning investigation. It may mean more than 1, more than 10, more than 15 as well. So keeping in the mind, today actually we are trying to uh, penetrate the investigation, rather to say to understand, not to give you the list and the findings and others. So I believe all of you try to be concentrating to the discussion. Too much brainstorming discussion today. Please, we will try our best to let you understand. So before going to investigation or approach to the investigation, what is the approach to the patient? Our approach, actually holistic approach. So in the holistic approach, we are going with general observation, history taking, physical examination and investigation. And what is our target? Target are those or aim of these 7, 8, just as much as possible we have gathered. The investigation doesn't mean only for diagnosis. Okay, it is to exclude also other differentials, etiology, risk factor, complication, to see the functional status of the organ. Even for the research purpose also, we are doing some investigation, remember. But the process or stepping of thought process in the investigation, how we start with the history. I'm sorry, the text is not visible much, but I'm telling you, the big red area is for the history, the big area. From there, we summarize to plan for physical examination. So in the OSCE, those who are OSCE candidate, if anyone today, you understand, your skill will be focused examination. Okay. We can say focus history also, but in general, history will be bigger. And then come to a focus, means meaningful examination plan. And then for diagnosis purpose, the investigation passage will be narrowed here. So we were thinking that the planning of patient evaluation will be in a funnel way. That means a funnel shape approach. funnel approach rather to say. I don't know anybody told before or not. This is our personal thought process we are utilizing to share with you. So you have to think a patient exploration evaluation in a funnel way. That means they like a funnel. So how actually give the process or approach will give us the information. Information means the history guides us for examination. History plus examination finding guide us for the investigation plan. This is our target today. And the history examination investigation all together guide us for proper management plan. So we are telling it is a funnel approach. Try to remember it the later on. Now, what are the investigation types we are utilizing? According to the, what I say, location or according to the modality. If we say nowadays, one word I think most of you already know about, it is called point of care test, POCT. I will let you know a little more. And some tests are recognized as laboratory test, some are imaging, and some are invasive test, biopsy one of that, or even the endoscopy invasive test. Therapeutic trial also can be a test. Rarely it is done. Okay. But some other tests are called physiological and the functional test to see the function of the organ. For example, ECG, echocardiogram. Echocardiogram again I'm telling it is not a specific only the function. You can see the structure of the heart. So echocardiogram is telling us the function of the heart as well as the structure of the heart. Stress test, EEG, and pulmonary function test. All of you know about this. So what about the point of care? As most of us today, possibly the family physician and going to be family physician, a specialist in future. So this topic or these words should be known. Point of care test. That means at your chamber place, what test you can do. So today we are showing you see many tests are available in the point of care. Many. But don't think that it is a competitor of the laboratory test. It is just to get the information at hand very early, very simply in your chamber. For example, capillary blood glucose. Capillary blood glucose. Okay. So point of care test is actually a form of testing analysis performed where healthcare is provided close to or near the patient. So another name is near patient testing. In Indo patient, we say bedside test. Very simple test. Okay. But there is disadvantage then the laboratory test is the quality control is not easy. The staffs are not that much trained up for practical purpose. Sometimes the reagents and the machineries are not that well quality. But even then, for example, capillary blood glucose measurement many years before in our hand and giving very good result, and we are taking decision also. But you know that by seeing the capillary blood glucose, we are not diagnosing diabetes. The method and recommendation is to diagnose the diabetes. We have to send blood for testing to the laboratory. Okay. And till now in the world, the list will be increased, no doubt. Blood glucometers, number one. These are example of the point of care test. Urine dipstick, pregnancy test, many years you know about pregnancy test. Stool test, blood gases and electrolyte. These are not much available. Uh, Wherever the emergency investigation results are needed, at that time we use point of care test. Even hemoglobin or hematocrit also possible to be done in your chamber. Rapid HIV and rapid other organism test also in South Asian countries now, including my country. Rapidly we can test now even the COVID, malaria, dengue as well, many. So these list actually not a completed list to show you only for example purpose. Now come to the area of hematology. The test definitely CBC will be number one hematologic test. But before that, we need to assess our patient. Dr. Javed, anyone start with us to read the patient? Dr. Javed, please.
Sure. A 75-year-old male presents with 2-month history of dyspnea, weight loss, and generalized lethargy. Initial investigations.
I am just actually, patient is single. We are learning stepwise. So try to be concentrating in our stepwise discussion. So after Dr. Javed, I request other colleague to respond for the next question. Dr. Javed, actually initial investigation means what do you understand here?
I mean, considering the history, initial investigation.
No. Actually, this is the test. My question is it point of care test is possible for the patient?
चेस्ट एक्सरे
Chest X-ray. Why, Dr. Tanjit? Why chest X-ray?
और ये दिस इज आई थिंक कार्सिनोमा लंग
Carcinoma lung, 2 months dyspnea, weight loss, generalized lethargy. It's a very non-specific feature. If carcinoma lung, there should be some chest symptom. If you think that dyspnea is chest symptom, it is a rather semi-specific symptom. Sorry, Dr. Tanjit, you have problem in your audio. Please try to correct it in future also. Dr. Javed, where is the disease you are thinking?
Dyspnea, weight loss is dyspnea. I mean,
75-year patient, maybe malignancy. Anywhere, right? Maybe. But what Dr. Tanjir said, actually history is not guiding us to say that disease in the lung. Maybe disease in the lung. So we are actually dealing with some non-specific presentation. If we say dyspnea is not a specific. If you say what is the specific, more specific symptom of the lung disease, this is the cough with sputum. Okay, Dr. Javed? Cough with sputum. It is not mentioned here. So this is the non-specific. There are some in our body, there are some systems where presentations are non-specific. For example, endocrine disease, non-specific. Hematologic disease, non-specific. But disease may not be there also today. Anyway, in the initial investigation, first question, we will be thinking to do one CBC. And this is the CBC finding. CBC is universal screening test. Okay. But actually, I was asking, do you like to do any point of care test here? For example, could it be blood sugar check or any other, Dr. Javed? Possibly no. But as a routine, answer also yes. Answer also yes. But as the symptoms are non-specific, we need to start with a non-specific test. I discussed before also, CBC is a general test. Mostly we will tell it general test. So disease may not be in the hematology also. Now what you are thinking or you are getting the information and what your summary now? Where is the disease, Dr. Javed?
MCV is high, and then there's look like pancytopenia. WBC is low, platelet is low.
So where is the disease? What is the disease? And the urine analysis showing urobilinogen. Where is the disease? Dr. Ramesh?
Yes, sir.
Where is the disease?
So according,
Is vitamin
yeah,
B12
it's
or
like a
folic acid deficiency?
No, I'm telling you, where is the disease possibly?
so it's in the bone marrow and it
Bone
has
marrow.
associated with liver. Yeah,
Liver problem because this
liver
bilirubin.
mets also
Liver
yes.
metastasis from some other organ.
From bone marrow.
From bone marrow. So what type of disease in the bone marrow? Overactivity or less activity?
Less
Less
activity.
So if it is a less activity, how can you say that this is metastasis to the other organ? Again, if we say metastasis to the other organ, what are the other organ feature? If you say the lung, where is the lung feature in the presentation? Today's class, it will be very different class today. Dr. Ramesh? No lung feature.
Yes.
No lung feature.
No lung.
No lung feature. If we think that the etiology could be here in the MCV, hemoglobin low, WBC low, platelet low, MCV is high. Okay, as a pancytopenia, disease in the bone marrow and less active. What is the reason of the less active bone marrow? Not that it is always malignancy there. Dr. Javed, if we consider MCV, high MCV, cause of high MCV causing anemia. Now you can answer. What deficiency? Iron,
B12 and folic
folic
acid.
acid, or B12
Then
deficiency?
B12.
B12 deficiency.
Vito.
So if it is so, how can you explain the urobilinogen? That is the features of the RBC breakdown. Is it again tell that liver disease is there associated without any clinical background? If clinical background is there,
Hemolysis.
hemolysis is there. So what will be the next appropriate investigation now? If you think hemolysis,
Coombs test.
Coombs test, autoimmune hemolysis.
Yes.
But could there be mechanical hemolysis? Hemolysis due to many other problem also. Again question is that if the vitamin B12 deficiency is there, can it produce hemolysis in the disease process? Someone open the mic, please. Please share. Even we can discuss the single patient 1 hour also. Though we will not do it. We have to proceed to show you some other example today. Dr. Ali, please.
Vitamin.
So megaloblastic anemia, which these cells are bigger size and prone to hemolysis.
So these age elderly patient might have nutritional deficiency. Okay, we agreed. But if there is a hemolysis, will we go for the liver function test full? Who can say?
Yes, sir.
So
Yes.
should be, yes.
Should be. But
Yes.
but again,
You
go
have
back
to-
to the patient. Always consider the patient. Patient is not giving any clue of liver disease.
The reticulocyte count will consider whether it's bone marrow depression or hypoplasticity. Reticulocyte count.
Reticulocyte due to hemolysis. So can we
Whether-
expect hemolysis in B12 deficiency?
No.
No, sir. No. Sir.
No?
No, it's hemolysis.
Yes, there will be the discussion. Come now. There will be the
Connective
discussion.
tissue disorder.
Doctor, be with
Multiple
me now.
myeloma.
Be with me now. Okay? Don't expand the discussion. So next investigation, you can choose now from there. What you are thinking, they are also thinking direct antiglobulin test, bone marrow aspirate, endoscopy. Somebody thinking endoscopy, serum haptoglobin. These are the features of hemolysis, right? Serum haptoglobin. And the vitamin B12 concentration. So are we going to diagnose the etiology, or are we going to investigate some other allied informations? Considering this thing, you can choose the answer now from here. What will you do? What investigation will you do from there?
The bone marrow aspirate.
Because you are thinking bone marrow production is less. Okay?
Yes.
That's good. That's the idea. What we are expecting in the bone marrow? Less production of the cell precursors, right? But what is the reason? Okay. Another colleague to choose any other test from here? Endoscopy. Patient does not have any GI feature, number one. But how endoscopy can help us in the pancytopenic patient, where MCV is high? If it is, we are thinking pernicious anemia. Pernicious anemia, again due to what? Pernicious anemia? Due to B12 deficiency, is it?
B12, yeah.
So before going to it to decide endoscopy, it's not better to see whether B12 deficiency first? If you think stepwise that what is the inner disease, if you think that this is pernicious anemia, so we have to consider first to detect there is B12 deficiency or not. So endoscopy is not the next step investigation. Okay. Moreover, in the patient history, there is no GI symptom. So how to summarize now our plan? Other colleague are listening only. I don't know how much you are thinking today. This will be the best answer. Those who are appearing in the AKT exam, it is your best answer. Those who will be appearing in the OSCE, it is your answer to explain to the patient. Okay? That by getting the initial investigations report, what will be the next investigation? This is the investigation skill will be tested in the OSCE. We told you before also. Okay, you can do many tests for bilirubin level and other liver function test. You may think it is justified, but it is not justified. One confusion is there, most of you telling that as there is a bilirubin, we have to go for the liver disease. But if it is megaloblastic anemia with other features, there is a high bilirubin level. Due to ineffective erythropoiesis, there is breakdown of the RBC. Ineffective erythropoiesis due to lack of B12 deficiency, there is breakdown of RBC. Now, if I tell you that make a complete list, especially for OSCE candidate, who can tell me now a complete investigation plan of previous patient? Look at please again back. Start with the CBC, then 75-year-old. A tricky question for OSCE. A tricky question. Make a complete list of investigation. Quickly, please. Dr. Ali, possibly candidate. What investigation you will plan for this patient? 75-year-old male.
CBC,
Right.
ESR,
Okay.
and vitamin B12 levels.
Very right.
And in the last, if we couldn't found, we will go through for bone marrow.
Right. Very right. Very right. Very right. Any other investigation as a part of patient management? I'm telling in the OSCE station. Dr. Ali, sorry for Dr. Ali. Dr. Ali targeting only diagnosis, right? Whatever you said, these are diagnostic tests. But we started the discussion before. Aim of investigation is like aim of history taking, aim of clinical examination. Not only diagnosis, to exclude differential, to identify etiology, to see comorbidity. Dr. Ramesh, you tried to check the liver function test. What is the reason?
Exclude any liver enzymes deterioration.
Maybe. But if it is allied with the B12 deficiency, there may be slight rise of the bilirubin. It can explain also. Even then, should we go for the liver function test for such patients, 75-year-old?
Yes, sir.
Yes, why?
Because this is sometimes carcinoma can be some
No, always you
strange
say
reasons.
no, doctor, please, all of us, whenever we are asking this question, you are giving the answer, targeting always diagnosis in your mind. There may be carcinoma, there may be this thing. I don't know, Dr. Javed, do you understand what I mean? Always we are thinking there may be some disease, may or may not be. Then we are selecting that investigation. But we are not thinking very simply, very easily, that a patient may have liver dysfunction for any other reason we don't know. We will give many medicine for the treatment purpose. We will go for further investigation, maybe some invasive investigation or contrast related investigation. Many other things are there. So as a 75-year-old male patient may have many organ disease asymptomatic, not related with this presentation. Clear, Dr. Ramesh? If it is true, we have to include liver function, we have to include renal function. Even we will go with an ECG also. Understand?
Definitely.
For holistic
just in a liver function, you can get some idea about bilirubin level,
definitely,
right?
additional. Yes, additional message.
Direct and direct bilirubin, the indirect bilirubin must be, because as you said, this is this is the only urobilinogen is high.
Definitely, I'm telling that if the urobilinogen is not high also, there is no clue of the bilirubinemia. Even then, we will include liver function test. This is the message. Because we are dealing a geriatric patient, 75 years old, very advanced age. That is the message to share with you, that our investigation plan not only based on diagnosis. For many other purpose, we go for the investigation, but our first priority is to diagnose the case. Okay.
One will do intrinsic
Yes.
antibodies to rule out pernicious anemia.
It depends upon our efficiency as clinician. For example, 75 years old is not actually age of autoimmunity. Patient come across the age of autoimmunity earlier. Patient would present earlier for the anemia, and patient maybe in the 30 or 40s. Okay, Dr. Javed?
Thank you.
Almost most of the autoimmune diseases happen in female and the 30, 40 years. Our patient is male.
He's old, very old, 70 years.
So your argument will be weaker. I'm not telling that not indicated, weaker. We have to check priority investigation first. Then we can decide. If no information found, then we can search for the second tier, third tier, moving around. Okay. Anyway, so this will be an investigation list for the OSCE. Now, the summary of this. Actually, we gathered some principles of investigation. We will show you at the end of discussion today. We have to think CBC is a universal test. For any disease, you can utilize it. Number one. Second observation is prefer non-invasive test than invasive test or before invasive test. So in our previous case, what was our invasive investigation planning, but we are not going to start?
Bone marrow.
Bone marrow or even the endoscopy also. Yes. For example. So we are not going to the invasive test, but our common sense is that wherever the pancytopenia, look at the bone marrow. But it is not always true. If it is vitamin B12 deficiency, even after diagnosis, vitamin B12 deficiency, we can start the treatment without going to the bone marrow. Sometime it can happen. Again, if I give another example, SLE, RBC low, WBC low, platelet low. We are not going to do the bone marrow study. We are giving the treatment of SLE. That's enough. There is a pancytopenia. Anyway, so this is the discussion for you now. In the mild jaundice happen in the B12 deficiency due to ineffective erythropoiesis. So this jaundice, don't think that due to liver disease. Okay. So these are the academic discussion. All of you know how to proceed with the high MCV, right? Megaloblastic, normoblastic. I think all AKT learner know about that. Definitely those who are preparing for the OSCE, you know it. Just to give you a glimpse that what we are discussing now. So come to some informations to share with you from the CBC report, complete blood count. Interestingly, especially maybe in the South Asian countries, CBC include ESR. Even in my practice place also, if I advise, they give CBC as well as ESR. So area to area, doctor is to know what we are advising and what our lab is providing. But in general, CBC does not include ESR. ESR is ESR rate, right? Sedimentation rate. CBC almost, these are the count. This is a tradition. So in the CBC, these are some misleading results can come out from CBC by autoanalyzer. So you have to remember it. Okay, I am not discussing this. You already gone through, and we can provide this slide to the group also. Increased hemoglobin, not due to actually increased hemoglobin. There are some technical explanation. But in the dengue season, South Asian countries now, what we are facing, platelet count. Platelet have tendency to clot. So platelet count usually shown less by autoanalyzer. So these are some technical message you will go through. And in the MCV or the hemoglobin concentration, this is the color, how it produced. Immature cell is bigger, and the iron, the lack of iron, you see, cell becomes smaller. So this is the two extreme. One is a big cell, one is a small cell. So I am just telling you the quiz now. Who can answer? Get ready. A patient having iron deficiency as well as vitamin B12 deficiency. It is also common. what you expect, what will be the size of the RBC? Is it smaller or bigger? Neat outcome is a small cell or big cell? Who can explain? Can you try?
Mixed picture.
Mixed.
Some
Okay, one
small, some
possibility is the mixed. But if I tell you why you are thinking that there is a mixed picture smaller, naturally precursor cells are bigger. From bigger, they are going to be smaller by iron deficiency. Okay, iron
The
deficiency.
smaller.
But
Smaller.
if vitamin B12 deficiency is there, cell will be arrested here. Isn't that it? B12 deficiency, folate deficiency will arrest cell size here. If you say there is iron deficiency, will you think that this iron deficiency will pull the RBC to down? Less likely. So, summary is that if you get only big size of the cell, we are telling this is B12 deficiency, but there may be hidden iron deficiency also. Understand my point, Dr. Javed? Maybe very exceptional thing I am telling now. If big cells are there, it usually indicates vitamin B12 deficiency, but there may be hidden iron deficiency. If there is no B12 deficiency, definitely the cell will be smaller. Just hidden information. Anyway, now very interesting is how to differentiate iron deficiency anemia and hemolytic anemia in complete blood count. Okay. Or hemolytic anemia, or maybe the B12 deficiency also, we can say. That means according to the size, by looking the size of the cell, we say this distinction is very important, because you know the iron deficiency causing microcytic hypochromic anemia and hemolytic anemia also causing macrocytic hypochromic anemia. So here RDW can help us. RDW, it is called red cell distribution white. It means the variations of the morphology of the RBC. If more variation, it indicates iron deficiency anemia. Less variation, hemolytic anemia. For example, thalassemia. Another index we are using is Menzer index. Menzer index, MCB divided by RBC count. So MCB, that means the unit given in the blood report, CBC report, and RBC count in the million. So if the result is less than 13, it indicates thalassemia. If result is more than 13, it suggests iron deficiency anemia. Okay, this is an assumption. Our understanding level will be high up if we can consider RDW, if we can consider Menzer index. So again, if you think there, if why it is less than 13 indicating thalassemia, again, you can understand that the variation will be less in favor of RDW. So in the CBC, you can check this. Very simple calculation. So now a blood report shown to you, what you are getting. Dr. Ramesh, can you see the report is visible? The results are, look at the age first, 48 years, okay? 48 years. So a mature, gentle the woman, Mrs.
Yes, sir.
Mona
Female
Begum,
patient.
female.
Yes.
So hemoglobin is little low, right?
Yeah.
But the female
Yes,
range,
sir. 11.
according to the report,
Normal.
adult male, female 13 plus minus 1.5. So it is a little low, mild anemia. ESR 42, WBC 9. Everybody look at and try to tell me what is your impression while looking the report. Is it normal? No normal. If we say it's a mild anemia, what is the type of anemia? Microcytic hypochromic. Dr. Ramesh? Or
Yes, sir, it's
normochromic
like
or normocytic. Look at the MCB, look at the MCB, microcytic, 79, and here is 87. So how can you say this is No, doctor. How can you say microcytic? Lower
No,
range is
RDW.
79. No. Look at the 79. MCV is normal.
The normocytic.
So we can say normocytic anemia. Normocytic mild anemia. But if you tell again RDW, okay, but important marker is MCV first. If you cannot decide from the MCV, then go to the RDW. What is the RDW?
Okay. RDW is high, 13.6.
13.6. So 12
It's
plus
normal.
minus 1, it is also normal. So RDW is normal. You cannot decide from RDW. If RDW is high or low, more likely then you can get help. But by the microcytic hypochromic, you cannot say here. It may be anemia of chronic disease. Isn't that it? Or even,
yes, sir.
Or it sometimes
Yes,
it
sir,
may
it's
be
high.
hemolytic anemia also. Okay, as there is no other cell line is involved, so maybe problem in the RBC first. Mild anemia. So in a female 48 years, there may be other clinical picture can guide us, maybe underlying malignancy developing, beginning, or there may be even iron deficiency anemia. But as it is MCV is normal, it is anemia of chronic disease. Patient might be suffering from rheumatoid arthritis, might be suffering from diabetic kidney disease. We don't know. So our history and examination will guide further. But for the point of hematology, as patient having anemia, an autoanalyzer we can rely upon though, but the better option is looking at the slide by microscope. So what will be our next step?
Blood picture.
Blood picture, okay. But we mentioned here 42. In the mild anemia, ESR is 42. Do you think that ESR is abnormal for this lady?
No.
No. What is the upper limit of the ESR of 48-year lady? Can anyone say?
I think it's 40, sir. 40 to 50.
Oh. There is a formula I discuss very often, possibly you couldn't pick up. You just divide the age by 2. What is the age of the patient here? 48. So if you divide 2, what is the result? 24.
20.
Okay, this is the result. Now for the female, add 10. What will be? 34. So 34 will be upper limit of ESR of this female. For the male, we will add 5. Clear? You can make a note also so that you will not forget it. So ESR just high, few digits high. If it is relevant with the etiology, ESR high in female, what disease could be there? High ESR may be autoimmune disease. Isn't it? High ESR may be due to
Rheumatic
anemia.
arthritis. Yes. Chronic disease.
Whatever the cause of anemia, even anemia can cause also high ESR. It is also true. Isn't it? If ESR is too much high, more than 100, in general, our clinical practice, we are thinking multiple myeloma, disseminated malignancy, even disseminated tuberculosis, few diseases, especially in South Asian. But by the blood report, we cannot assess. We have to consider the clinical picture. So for the anemia, to clarify further, our next test will be peripheral blood film. Now look at the peripheral blood film, what they are telling. Maybe not easy for you to read. They're telling normocytic normochromic red cells with some ovalocyte, few target cells, spherocytes, occasionally fragmented cell with rouleau formation are present. Many informations are there. Are we habituated to read in this way, Dr. Anuradha? Whenever we get the blood report, are we serious to read like this in our report, in our practice? Dr. Anuradha, can you not hear me? Yes, always. Are you reading this each and every word? Practically,
I read the comment section.
Yes, this is our habit that I asking. So better to read it because, for example, if it is an iron deficiency anemia, they will tell there is some ovalocyte, right? Poikilocytosis, many other things. So if it is very significant, for example, target cells are more, then we can think hemolysis. But in iron deficiency anemia also, there may be target cell. Rouleau formation indicates there may be region of high ESR. What is the reason? Antibody, autoimmune antibody, rollo formation, piling of RBC one above another. So this is the description of RBC. WBC mature, platelet adequate. What is their comment? Mild normocytic normochromic anemia. So what you are getting in the auto-analyzer report, the hematologist also telling the same after seeing in the microscope, normocytic normochromic anemia. So our next investigation after anemia by clinically, or usually clinically, if we get anemia, definitely we have to advise CBC with peripheral blood film. We will not wait that let's see what the CBC. Clinically anemia means there should be peripheral blood film. This anemia may be due to malignancy also, maybe leukemia also. We don't know. Okay, so this is the next investigation of the CBC, and this is the red cell distribution wide already discussed before how it is helping. Okay, right. I think I took a long time to make you understand the principle of investigation analysis with the clinical presentation, but we will jump now very quickly. And in the test of infectious disease, these are the tests to identify the microbiologic organism, right? Non-microbiologic test, some direct detection of the organism. These are the tests we are utilizing every day by the culture, and some immunologic test, antibody test, many antibody tests we are doing for the infectious disease. So CSF study and many others in the meningitis. But what about the CRP and ESR? Are we doing these tests only for the infection? No. It give many informations. So you see in the connective tissue disease also, ESR always important. But how CRP may be important in autoimmune disease, for example, SLE, Sjogren's syndrome, multiple myeloma, it is not connective, it is a hematologic disease. Pregnancy, old age. Just to analyze these, look at please. CRP are normal here in these conditions. Okay. So we are thinking an inflammatory disease, for example, SLE, joint pain there, skin features are there, malar rash there. Almost we are getting high ESR, but we may not get high CRP. Initially, usually CRP is normal. It can give some diagnostic information for the ESR, for the SLE. But again, not only SLE, there may be some Sjogren's syndrome also, some other even scleroderma also, some connective tissue disease, CRP may be normal, remember it. But what is the benefit of doing CRP? Even in the background of infectious disease, other than ESR. Can anyone say, please? If you cannot say, so I like to say that never prescribe CRP in your practice. So you must say today because you are advising CRP, I believe. Who can say?
For CRP, acute event, acute infection.
Acute means acute. For example, a patient have pneumonia. So we advise ESR, we advise CRP. Which we prefer?
The CRP.
Why not
CRP.
ESR?
ESR will be chronic inflammation is there then.
No.
Need for selection of antibiotics, whether we have to give antibiotics.
No, doctor, no, not antibiotic by the CRP or ESR. Actually, to see what Dr. Javed said, that inflammation is, the process is happening inside or not. But initially for the first day, just to have in your mind, ESR change happen in usually at the end of one day. I cannot give you the reference, but I remembered in my mind. ESR change happen usually end of one day, wherever the disease, not in the lung, everywhere. But CRP changes after hours. So to detect inflammation, CRP is better than ESR. Clear now, Dr. Javed? Again,
yes, sir. Yeah.
Again, in the follow-up of the patient. Okay, rheumatoid arthritis and other connective tissue disease. We are asking the patient, do you feel better? Sometimes patient answer is confusing. We cannot understand the disease is improving or not. In those situations, we have to rely upon the investigation. Again, ESR will be changed in the later time. there is an improvement, maybe 8 hours improvement from before. At the end of 8-hour improvements, ESR may not be changed, but CRP will be changed. Understand now? So if we need to see hourly outcome of the treatment, so which will be the best test? CRP or CRP? In this way, CRP is better. There are many other explanations why CRP is better. There are, the sensitivity and specificity of the investigation. We discussed in biostatistics classes. So in this respect also, CRP having more sensitivity and specificity. In this way, CRP useful. But what is the disadvantage of CRP? As we are family physician, it is the cost. Again, in the CRP, range is not fixed. We have to check the range according to the laboratory given. Somewhere it is 10, somewhere it is 5. Remember it. Okay. So these are the CRP issue as we are giving the advice in the infectious disease. So we explain as much as for you. But remember, in the multiple myeloma, CRP may be normal. So whenever you confront with a disease, having the differential diagnosis of the multiple myeloma, you can utilize this information like SLE, because multiple myeloma present with the bony pain, whole body. You may think it is a connective tissue disease. So connective tissue disease, ESR is high, CRP may be or may high or may not be high. But in the multiple myeloma, CRP normal. By looking the CRP also, you can differentiate this is multiple myeloma or other connective tissue disease. So it is written in the book as well. Okay. Right. Now come to the second patient. Dr. Anuradha, if you don't mind, can you read the patient for us?
A 30-year-old man developed a febrile illness 1 week after returning from a 2-week holiday in
Hill district of Sudan. He was admitted complaining of myalgia. On examination, he was febrile 39 degrees centigrade with mild icterus. There was no lymphadenopathy. Can we do any point of care test at the bedside? Whatever is not bedside, in your chamber. Can anybody say? Immediately in the chamber. I told you there may be blood glucose test, there may be deep stick urine, there may be other tests as well, malaria test, there may be HIV test, if test kits are there. Dr. Javed, any point
Malaria.
of care test? Malaria, right? Point of care test. So can we practice in future if we suspect those? Especially any Sudanese colleague are here, they can tell better. Even in my country also, there are hilly district there. And we have done it also in my training period. I can remember there was a strip immediately within minutes we can check. So the point of care test can be done. Okay. Point of care test can be done for the malaria, no doubt. Okay. Malaria may be positive or malaria may be negative. Okay. But there is a myalgia. Maybe patient might have myalgia also, malaria. 2 weeks holiday is there. What could be other than malaria in the hilly district coming back? 2 weeks holiday, remember. What is the holiday means? Dr. Binoka, what do you think holiday means? Enjoyment.
Leptospirosis antibodies?
No. Holiday, what is the significance for ours as a doctor? Your patient returned from holiday. Holiday means pleasure trip, right? Moving holiday to your country, Sri Lanka, Pakistan, Thailand, Singapore, holidays. So we know the activities of the holidays. So by the holidays observation, what disease could happen other than malaria?
HIV.
Maybe. Or enteric fever. Hepatitis. But if there is no clue, we have to do many point of care test. More than one point of care test we could do. But there is no lymphadenopathy. Okay. So lymphadenopathy is a common feature in the HIV. For that we tell infectious mononucleosis syndrome. So HIV less likely. Rather, it may be malaria or other. Anyway, malaria slide test may be point of care test. Actually, I am intentional today with you to let you know in the family medicine, this point of care test will be very relevant and very useful. So after that, what will be the next investigation plan? For example, you cannot get anything in the malaria test. It is negative. Then next investigation, what could be? Again, it is an station for your OSCE. Remember, the return, holiday return patient. Dr. Ali?
Sir, CBC urine analysis.
CBC urine analysis. Let us see. Very right. So CBC showing like this. And what will be the most likely diagnosis now?
Malaria.
If I ask you, sorry. If I ask you in this way, what is the most likely diagnosis? This question will be to your OSCE candidate today. Understand, Dr. Ramesh? Because
Yes,
in
sir.
the OSCE, they will not tell you this 5 option, right? So up to this, your question. Dr. Ramesh, another OSCE colleague today here. So what is your most likely probable diagnosis, for example? But you have done an investigation also.
Dengue.
Dengue.
Count is low.
Dengue. Okay, dengue. But for AKT examinee, this is the question. Dengue. So let's see now. This is malaria.
Malaria. Yes.
So what clinical information forcing us to say this is malaria? From the hill district, hilly district of Sudan or any other hilly area. Okay. But there is a myalgia also happen in the dengue. And 1 week after returning from 2 weeks holiday, 1 week after returning could be a clue also, because in the dengue incubation period is 3 to 4 days. Even then, if you say this is malaria, it is a possibility. For this reason, you have done the strip test before. Okay, I told you malaria negative, so less possibility. Second possibility, maybe malaria, could be, but not HIV. Not HIV, because lymphadenopathy is not there. Now, if you think this is a malaria, what will be your next investigation? Thick and thin film, right? Thick and thin film. Now, for the OSCE candidate, Dr. Ramesh, summarize your investigation for this patient quickly.
The initial test, from bed point test, it is we have to check for a malaria. It is negative even, so we have to go for a CBC analysis. And
Sorry,
if the
Dr.
CBC
Ramesh,
analysis,
you are including malaria, but why not dengue?
yes.
So you can we can include not only one diagnostic test. When we are confused by the diagnosis, we have to do more tests. So in your point of
Yes,
care test, in the point of care test, not only malaria, we can include dengue also. Okay.
Okay, sir. Dengue is coming like POCT, right? Bedside test.
Yes, it's bedside test.
Then
It
in
is
December.
possible. Yes.
Okay. And then we go for CBC.
Then
and then liver function.
Yes, liver function. So wherever the fever, there should have a liver function test. Remember it. In the malaria, maybe jaundice may not be visible, but wherever the fever, infectious disease, we must include liver function test, because malaria, hepatitis E, even the dengue infect the liver also. So again, liver may be affected non-specifically without hepatotrophic virus also. Okay. Can we include any blood culture?
To see typhoid.
Yes, can we include blood culture?
Yes,
Maybe,
blood culture for a typhoid.
again, maybe. Is there any investigation, primary investigation feature against blood culturing?
Yes,
leukocyte
count. Its leukocyte count is normal.
Normal, but do you think that the all enteric fever patient having leukocyte count low always? No. Though we learned from the book, leukopenia can be a features of enteric fever. So blood culture may be a second line option here. We can include also. Okay. For AKT again, up to this enough. But for the OSCE, you have to consider blood culture also, because we don't know patient today febrile, when it will be ended, how many days later it will be gone, we don't know today. Clear? So a febrile patient,
Yes.
blood culture always will be justified. If clinical clue is not very focusing. It is again, you see, non-specific feature, fever, myalgia. We are thinking that this is in the muscle. Actually, no. This is somewhere else, not in the muscle. Mild icterus, there is a jaundice. So now we think that in the enteric fever, patient may have jaundice or not. Yes, though uncommonly, patient may have jaundice. So we can include blood culture also in such background, but it may be second line investigation. So for the OSCE, you have to think a little in an expanded way with clean-cut explanation. Surrogate can ask you suddenly, doctor, why you are checking my blood culture? Are you thinking something dangerous bug in my blood? You need to give the explanation. Okay. So what is the summary? This is actually, I told you, we tried our best to create some principles of investigation. Actually, we didn't get anywhere. In my personal, rather to say, thought process guiding me to summarize in this way. To diagnose without a specific diagnostic test, clinical data and non-specific investigation result should be considered. Dr. Ramesh, I think you understood why I said you that test not only malaria, you test the dengue also. So as non-specific results are there, okay, and clinical data also non-specific, we have to do more investigations. That means without a specific diagnostic test, we have to proceed on. Then finally, we will go for the blood culture. If malaria negative, dengue negative, days are going 5, 6, 7 days, patient is still febrile, definitely we will go for the blood culture. Even in South Asian countries, what we are doing, before getting the blood culture, we are treating as enteric fever and we are getting the benefit. Those who are utilizing as a clinician, you know about. So up to this, I think you understood as we are going slowly. Now come to urine report, some urine report. So urine analysis. In short, we are telling urinalysis. Okay. So anyone here, colleague, do you do deep stick urine test in your chamber? Any colleague? Please, we will be very happy to know. Dr. Ramesh possibly no. Is it, Dr. Ramesh? No.
No, sir.
No.
Actually, my system is little different.
Okay, Dr.
Yeah.
Anuradha possibly doing, right?
No, sir.
No? Oh, you are telling no. So anyone to say yes? No one. So what I like to say, we are far away from our family practice. Still myself also doctor, though I am not officially recognized family physician. I'm medicine specialist in my institute, but in my heart, okay, all of you understood in the meantime, I am actually feeling best as family physician. But as I don't have my personal GP center, I don't have this thing, but I am teaching or I am guiding my followers to establish the family center or private GP center and advising them to organize this point of care materials. It will be useful in a business point of view also. You see how many information we are getting. Many leukocyte, other many diseases, right? Blood, pH, protein, sugar, many things are there. So it can give a lot of information, deep stick urine test. And you must know how to do it. To keep it in a horizontal position, you can learn by yourself. So this is the urine analysis. Within a minute, you can get. So I am encouraging you personally. And this is the bigger picture for you. There are some second that after you have to wait up to this time to get the perfect result. We should not be hurried to get the correct color, and even now you know how to match the color with this standard color. Then it can give some message to you. Okay, so it's a bigger one, and even the pH also, ketone also. You see where we use ketone, Dr. Ramesh?
DKA and the
DKA.
pregnancy
So
time.
for example,
Yeah.
in an OSCE case, you are facing a patient of high blood sugar. Patient is confused. High blood sugar. Patient is insulin dependent. Definitely, you need to know about ketone, right? So
Yes,
in
sir,
the
definitely.
ketone in the blood, will you get the ketone in the blood immediately within minute? No.
No, sir, it will take
No.
time.
But you can get some idea. Though there is some false positive, false negative result in the urine. If there is an ketonuria minimum, we can say, if you consider with the clinical presentation, there is a ketone in the urine, we can say more likely patient now develop diabetic ketoacidosis. So what will be your responsibility diabetic ketoacidosis in your chamber now? What will you do?
Yes, sir. Urgently we transfer to the patient for the
Yes,
high
transfer to
center.
the patient. This is the number one step. Other thing, fluid is there, fluid loss is there. I can make an IV channel. Many actions we have to take, but our priority plan will be refer the patient, sending the patient. So your urine ketone can guide us also, right? Our urine ketone can guide us. For example, I am telling,
Yes.
so ketone, glucose, protein, okay, many information we can get. Even for the UTI, leukocyte esterase, there are nitrite, and there may be some strip may contain more than this also, more than this test also. Country to country varies. Maybe there, and possibly that there are microalbumin strip, urine strip also available in the world now. Microalbumin urea detection. Okay. So I think in South Asian countries, we are far away from there. Maybe very sophisticated and very high profile investigation center are doing. But in general, microalbuminuria strip not available. So that is the thing, but these are very commonly available, very commonly available. Something about evaluation of the urine test. I don't know, all of you before thought of this in this way. It's a big discussion there. I am not telling everything. Just I like to tell you the specific gravity, for the specific gravity, diagnostic test is not a good test. And remember that the diagnostic result showing at the time of testing, not in general. Okay, at the time of testing. And there may be some false positive, false negative result, especially for blood. False positive blood means there is no hematuria, but strip showing positive. Very commonly maybe menstruating lady or rhabdomyolysis. There are some drugs. Okay. Again, if you come to the urine glucose, there may be some false negative also with ascorbic acid. What does it mean, Dr. Ramesh? Ascorbic
see.
acid can tell urine glucose negative. Can you explain it? If person urine contain ascorbic acid, side by side, patient have high sugar in urine. For the reason presence of the ascorbic acid, urine will not show presence of sugar. So this is the false negative result. Okay. Again, false positive. False positive. Maybe due to peroxide, chlorine. These are uncommon, but salicylate medicine is common. So presence of salicylate in the urine can hide the result of blood sugar. For this reason, though, nowadays glucometer is developed many decades before we are utilizing it. Even then, by the urine dipstick, we are testing the urine dipstick for many other reason. This is an additional information we can consider. Now the protein again, you see how commonly in a reproductive age of male, a little mixture of the semen can tell there is protein. But actually patient does not have proteinuria. So I am not against the point of care test, but letting you know that we should have in our mind when we are utilizing these devices. Okay. I am very actually eager to tell you something very interesting. 1 plus we are measuring, 2 plus. What will be the level? If you can make a snapshot, you can preserve it. You may not get everywhere this message. 1 plus dipstick means at least 300 milligram per day. Per day, remember the word, not per liter or per deciliter. Per day, macroalbuminuria. So 1 plus means usually macroalbuminuria, but it can give some, preferably to say semi-quantitative amount. Okay. 4 plus protein can be more than, it is an estimation only. You are testing 4 plus on the time of testing, on the spot, but it may be an expression of 24-hour urinary protein more than 3.5 gram per day. How it will help? It can help us for the diagnosis of nephrotic syndrome. And it may be more than 1000 means milligram, okay, or 1 gram per DL protein. So this is a semi-quantitative assessment, 1 plus, 4 plus. For this reason, if we have a patient generalized edema, definitely we go for deep stick urine test. On the chamber, you can have an idea confidently patient might have nephrotic syndrome. Okay, Dr. Ramesh?
Yes, sir.
So overall, we have to say that this is an estimate assumption. So what we will do finally, we will go for the 24-hour urinary collection to check actual value is like this. Most of the time we will be right. Most of the time we will be right. And in the total urinary protein measurement, again we use albumin creatinine ratio, is it? Or
Yes, sir.
protein creatinine ratio. Again, we don't need to collect 24-hour urine. So it is available. That I told you before, that ultra sensitive dipstick, it can identify macroalbuminuria. May not be available in South Asian comparatively poor country. And these are the reasons. So we should have this in our hand also. In our hand means if you may forget, don't worry, your mobile phone is there. So you can keep it a snapshot also in the mobile phone. Immediately you can correlate this. Don't worry nowadays. I am very crazy to say that today, to tell you, because we are advising the medicine to the patient. This is our job. We are earning money. But how medicine can hamper our result in the domestic urine test? So any other colleague who want to talk? Dr. Ramesh is here. What medicine we are using from the left-sided list, drug list, commonly?
You're using the antibiotics.
Antibiotics.
Yeah, cephalexin.
Cephalexin, nitrofurantoin, sulfonamide. So
Sulfonamide
this
dose.
antibiotic, how it is influencing the urine result? It can cause leukocyte studies falsely. False result mean presence. Okay. So we are antibiotic, we are using antibiotic, but we are getting the urine false leukocyte studies. What we can think? We can think that possibly still infection is there.
Yes, sir.
Is not it? So it could be common
Yes.
mistake. But we are considering infection not only by the presence of leukocyte studies. We are checking pus cell, we are checking clinical features as well. Okay. Again, we already discussed ascorbic acid. Okay. If a person take ascorbic acid, how we take ascorbic acid? Vitamin C. Maybe more vitamin C tablet chewable,
Multivitamins, yes.
or for some reason we are giving parenteral vitamin C. It can produce false negative glucose. That means patient is diabetic and patient passing sugar with the urine. In those cases, the dip stick can show zero glucose, no glucose. Okay. But ascorbic acid can show presence of blood falsely. So we have to keep in our mind. Levodopa we are using for the Parkinson's disease. These are chronic medication. Levodopa can tell us there is a blood, there is a ketones. Sometimes dipstick can confuse us. So this is the thing. Rifampicin always in the antitubercular medication, it can color reddish or orange color, right? Orange color. So it can confuse us as a blood. And dipstick also may be confused. Anyway. So urine microscopy, these are the results, and high power field equivalent to such and such. Okay. Please, my beloved colleague, if you don't understand my talk, always you feel free to discuss. So in the red cell, more than 2 is significant. Up to 1 normal. If it is 1, we are confused, we can repeat the urinary. Okay. That is in the next sample, maybe after 1 week or 2 weeks. Is there any presence of blood there or not? I can remember one question in AKT. I don't know, Dr. Ramesh can ask, can tell us that one young male, I mean the male health, one question, present complaining about, oh, that was not urine, was in the semen. There is a blood in the semen, apparently healthy. What was our plan of action? Follow up the patient, right?
Yes, sir.
So
This can
first
be
time,
normal.
normal. It can be normal. Similarly, in the urine also, presence of RBC may be normal without any symptom. But count is important. If it is more 3 or more than 3, it is significant. 3 or more than 3. So anyway, in the big book I am telling from 3 or more than 3, we will repeat the urine analysis. If it is more than 100, then directly we will go for identification of the cause of hematuria. It is second step understanding. Okay. So for the UTI pass cell, is it, you see, WBC more than 10. In high power field, 0 to 5 may be normal. 5 to 10, gray zone, 5 to 10. If symptom is there, we can start the treatment. If more than 10, it is significantly above the border. Okay. And very often we can get it. Sterile pyuria, culture negative. Even patient does not have symptom of UTI also. Patient may have pus cell or WBC, leukocyturia. One of the reason is after the treatment recovery, patient may have pus cell in the urine up to 2 weeks. Remember it in the follow-up patient. Or partially treated UTI, very valid reason. Patient may not have UTI, but appendicitis is there. So you know appendicitis, appendix in touch with the ureter, it can inflame the ureter also. Likewise, calculi, bladder tumor. So these are not infection. So message is that presence of pyuria does not mean infection. Okay. Now what type of urine sample we need to advise? Always we are writing in the prescription urine analysis or urinary. Dr. Javed, do you write in a different way other than urine analysis or urinary?
Yeah, yes, I think the same way, urinary.
Urinary. So actually it is the job of the laboratory personnel, how they will collect the urine. But in our field again, we are ignorant. We are not guiding the patient and our lab people also not guiding. What is your experience, other colleague? Can anybody say what lab people telling the patient to get the urine? What do you think? Nobody, please try to talk. Why not? They're telling that, oh, Mr. and Mrs., take this bottle or some container, go to the washroom and give your urine. Am I right or not? Do you think that our lab technician telling more than this thing most of the time? No, possibly no. But they need to explain how to take the urine, how to take the midstream urine. So anyway, as there are many different types of sample, I think in my summary is that whatever the reason of urine test, midstream urine is the best sample, including culture, including other microscopic examination and other. Okay, midstream urine, MSU. Okay. Fine. So SLE, IgA, these are all our SLE is a connective tissue disease, Actually, I'm showing to let you know significance of presence of proteinuria and hematuria. Okay, in the dipstick test, easily you can identify. If you are dealing clinically connective tissue disease, if patient have the proteinuria, you can think patient developed nephropathy. Right? The lupus nephritis is a very common bad outcome in SLE patient. So hematuria may be due to stone. Hematuria may be due to infection. But whenever hematuria, proteinuria, both there, more likely this is glomerular disease. Just to explain it. And commonly you may face a case of only proteinuria due to IgA nephropathy or others. But IgA nephropathy patient usually have hematuria. Okay, if you look at this picture, easily you can understand that SLE patient can present in many ways, only with proteinuria, only with hematuria, not only hematuria, always proteinuria, hematuria, both together. So try to understand the difference of this picture here. Hematuria up to these only, that is the spectrum from this point up to this point in the right and left. Hematuria up to these only. But left side of these, those patients will not present with hematuria. For example, minimal change nephropathy, amyloidosis, membranous nephropathy, focal segmental glomerulosclerosis. Okay, but this patient present with proteinuria. But here in the right side, from the right side, this patient present with hematuria and proteinuria both. But there is some degree of hematuria more and proteinuria less in the extreme. For example, anti-GBM disease, hematuria is more than the proteinuria. Okay. For example, IgA nephropathy is a common disease you need to face in the OSCE as well as AKT. IgA nephropathy. From here, you see, proteinuria, hematuria maybe more or less. Here also more or less. So spectrum of these, we cannot tell that in IgA nephropathy, hematuria always will be more. But few patients can present with the less hematuria with more proteinuria. So my suggestion to all of you, please look at the picture in your book, try to understand this thing so that the urine analysis report will be more comfortable for you. Okay. Up to this, now come to a patient again who feel better to read. Dr. Asma here. Any new colleague will give us pleasure to hear your nice voice. Any colleague open the mic? Dr.
Okay,
Asma,
sure, sir, sure.
please.
18-year-old student present to the student health service with frank hematuria that begins some 48 hours after an upper respiratory tract infection. On examination, he is apyrexial, BP is 110/72, and pulse is 70. His chest is clear and his abdomen is soft and non-tender.
Fine. This is our clinical background. Hematuria 48 hours after the respiratory tract infection. That means patient have the features of infection, upper respiratory tract. Maybe, Dr. Asma, can you keep your mic open, please? If you don't have any other work. So upper respiratory means maybe sore throat.
Yes.
Is it like this?
No.
So in such situation, hematuria developed at the time of infection. At the time of infection, within 48 hours, at the end of 48 hours. In such situation, clinically, what we are thinking now, who can say as a cause of hematuria?
Post-streptococcal glomerulonephritis.
So, Dr. Shazia, be connected, please. I am asking you.
Yes.
Post-streptococcal, word is post, but your patient is still within the illness. How can we say this is post?
Sir, it was
No, I'm
infected
telling for
first.
everyone for understanding of the terminology. We are telling post. We are telling many where post-infectious disease. Okay, reactive arthritis is a post-infectious disease. ITP is a post-infectious disease. Guillain-Barré syndrome is a post-infectious disease. What is the meaning of post? The primary illness is over.
Secondary.
Primary illness
Yes.
is over. But our patient,
Right.
18-year-old student, is the primary illness is over, Dr. Shazia?
Yes, sir. Throat pain is now not there. Pharyngitis is
No, doctor.
okay.
At
No,
the
no,
end
it
of
is
48.
ongoing.
Ongoing. It is
Ongoing
ongoing.
infection.
Ongoing
It may be
infection.
IgA nephropathy.
No, don't tell other thing. Just be sure about that it is not a post disease. Right?
Yes.
It is
Yeah,
not a
yes.
post disease. Be clear about this. Otherwise, your answer will be post-streptococcal glomerulonephritis, which is very common. So it is called synpharyngitis somehow at the time of the disease. So more likely this is IgA nephropathy. Okay. Keeping this in our clinical understanding in our mind, what will be our point of care test? Point of care already understood in the meantime. Everybody switch off the mic. Why? Keep your mic on. Point of care test, what could be? Urine? Dipstick.
Dipstick.
So you got the urine dip and your understanding is very right. So 3+ dipstick test positive. So you're now 50 or more than 50% confident this is IgA nephropathy. What will be the next investigation? You have done only dipstick test. There is a point of care test. What will be the next?
Urinary.
Urinary. Dr. Ramesh, OSCE candidate should tell now. Urinary.
Yes, sir. Urine
Okay.
analysis, yes.
Only urine analysis or any other thing?
Creatinine.
Why not
CBC?
CBC, creatinine,
basic
electrolyte as well?
CBC and
Yes,
serum.
yes.
Creatinine, electrolyte. Urinary will show you again the same thing. Anyway, Let's see now. So in the CBC, definitely urinary will tell, and we will get is there may be proteinuria as well. Okay. But as I picked up it from the AKT question bundle, so some investigations are not mentioned. So in the CBC hemoglobin and such, you are getting almost all are normal maybe or abnormal. Which of the following is the most appropriate way to manage him now? Will you go for further investigation or will you give treatment now? How will you manage, Dr. Ramesh, if it is an IgA nephropathy?
Watch and wait, sir. Watch and
Wait,
wait.
wait,
Yes.
only wait, or reassurance or
Yes.
assurance that no problem, maafi mushkil hai.
No. No. Wait and view.
Wait and see. Observation. Okay, you are telling observation.
We will review.
Okay, so any other colleague thinking differently, you can share. What will you do? You are silent. So this is the options. This is the observation. This is the observation. So for the AKT, your 5 stem, it is called options. 5 options will be given. You need to choose this answer. But for OSCE candidate, before giving this answer, you need to give the answer. This is the difference. So what I told before also, those who passed AKT, it is a golden storehouse, but you have to utilize in a different format for the OSCE. So your knowledge is enough. For this reason, we are encouraging all the newly passed AKT candidate apply for the OSCE as early as possible. Okay. Don't that only within 2 months, maybe 4 months to 6 months like this. Don't go beyond 1 year. You will forget many things. Okay. So this is the case of IgA nephropathy. Now, already you have given the answer. OSCE candidate, your task, make a complete investigation list. You already have done, including in the 18-year-old, if you think that already they have done some chest x-ray, is it or not? No, chest clear. They were thinking that there might be some chest lesion. So you can add some other, but this is enough for you up to this. So our summary of such presentation of with the investigation is self-limiting disease does not need more further investigation. I think all of you agree with me now. Now in the kidney disease, the differentiating point between AKI and the chronic kidney disease, simply to tell if patient present with the features of chronic kidney disease, so you can diagnose the case on the spot. On the spot means if your patient is anemia, patient have high blood pressure, and you advise ultrasound showing bilateral small kidney. Most likely this is chronic kidney disease. Okay, anemia, and anemia means again peripheral blood film will show anemia of chronic disease, not microcytic hypochromic anemia. And it is also true in the anemia of chronic disease, 15 or 20% patient will have microcytic hypochromic anemia. This is one of the way. But in general, our colleagues are confused when we get creatinine high. Immediately they are telling there may be CKD. It is wrong. Then we have to consider what about the previous investigation result, past history of high creatinine there or not. If the previous creatinine was high and it is more than 3 months, and in between time also we have checked, still creatinine was high. So by looking the creatinine, for this follow-up creatinine, we can say patient might be having chronic kidney disease. Otherwise, only by looking the creatinine, we cannot say. Second mistake, rather to say, is by measuring the eGFR. Mistake means eGFR again should be persisting more than 3 months. High eGFR. Though we are utilizing eGFR for the staging of the CKD, but before that we have to say this is CKD, then we can stage. So to define CKD, we have to follow the patient minimum 4 months. This is the message for you. And it will be very easy to understand if you can remember the chronic liver disease. Because in our life, maybe as a definition, chronic organ disease, we learned from the chronic liver disease. The features of the liver disease persisting more than 6 months. Likewise, in the CKD, persisting more than 3 months. Remember it. So it will be again a popular case in the OSCE with the nephropathy, diabetes, hypertension. Okay. In the GI, for the family physician, again, it may be point of care test, but usually it is provided to the patient to test in the house. It is called FIT, fecal immunochemical test, one of the method of fecal occult blood test. Okay, another name may be FIT DNA test also. They detect the DNA for cell particle and other. There may be even the malignant cell or others. So don't forget this. I think some organ related test now we will be with, and I don't know how much you can follow. If you are confused, please let me know. The serum, total bilirubin level, and the normal, and these are the normal level of enzyme, protein, albumin. Keeping this in the mind, this is an approach to the jaundice patient. Okay. History, again, history, liver ultrasound, urine analysis for the bilirubin, then go for the other test, conjugated bilirubin and other. This is the approach. Now my question to ask you, I will not explain this thing, it may take long time. If anyone has to ask me any question about this, is there anyone please to ask from this slide? Others we can proceed further. Dr. Rami is having any question?
Yes, in here they mention about liver ultrasound. When you have initially the test like we are going with urine analysis, liver function at all, then we have to mention about liver ultrasound if we find any jaundice patient.
Actually, liver ultrasound done for what purpose in the jaundice patient?
Exclude
to see any
cirrhosis, right?
obstruction, right?
Yeah.
To see any obstruction.
Yeah,
Or
obstruction.
sometime if we are confused, the jaundice is due to obstruction or not, then ultrasound will help. But interestingly, you can see in the book, though it is the latest edition book, we are starting the patient with unexplained jaundice. Dr. Ramesh, can you tell me one example of explained jaundice? Who can try? Explained jaundice. Explained means reason of the jaundice is obvious in the patient's presentation. Dr. Marcin, where are you, please? Dr. Marcin.
Drug induced. Right?
Drug induced. Yes, if I can have the clear history of the drug responsible for the jaundice, recognized drug, we can tell. But can we not tell that this is viral hepatitis?
Yes.
Dr. Marcin, not getting any other colleague. Patient having acute fever, usually 2 days later, fever gone, but patient developed jaundice. Abdominal pain is there, and you are getting tender hepatomegaly. What is this?
Viral jaundice, hepatitis.
Otherwise, patient was okay. So it is hepatocellular jaundice, right?
Yes.
Infectious jaundice, hepatocellular jaundice. In those cases, should we go for the ultrasound? Not needed always. Not needed always. We can go only with the blood test, liver function test, alkaline phosphatase, SGPT, prothrombin time to see the severity of the patient, of the diseases. Okay. Should we go for the conjugated and unconjugated bilirubin in viral hepatitis?
No, sir.
No. That is the message. Though it is shown in the book in unexplained jaundice, then it may be justified. But if I can explain, then all test is not justified. For example, heptoglobin, LDH, even the reticulocyte count also not needed if we are not thinking hemolysis. If patient have the anemia as well, then we can think hemolytic jaundice. But in the hemolytic jaundice, commonly patient does not have fever. No prodromal features like the viral hepatitis. In those cases, we will not include. This is the rationality of investigating the patient. How much I am able to let you know today, I don't know, but this is my exceptional, that was a special intention. It is very exceptional discussion from our side today. So for everywhere, patient evaluation is must. This is the investigation enzyme level, in which condition, how much it will be. In general, viral hepatitis, acute viral hepatitis, enzyme will be more than 300. But it may be less than that rarely. So, but chronic hepatitis, usually enzyme level is less than 100. So it should be in our mind. Should be in our mind. And there's some etiologic explanation, ALT, AST, okay, ratio may reverse. So possibly as a GP, you are dealing the liver patient as a primary physician. If you are confused, you can refer to hepatologist. But before referral, you can consider this thing, usually balancing between hepatocellular and obstructive jaundice. A very popular question in AKT also, causes of there. And these are the viral markers, including, we discuss many where, you see, this is the window period, okay? This is the window period. So I'm asking a question to you. Anyone other than Ramesh will answer, please. Then we can switch. In the window period, what will be the diagnostic test for hepatitis B infection? Please give the answer. In the window period, I don't know, do you understand? Window period means HbSAg will be negative here. But this is an still infective period. Acute hepatic disease means up to 6 months. But HbS Ag negative. So what will be the test in the window period to say there is hepatitis B?
Anti-HBC.
Anti-HBC. Can you add next word also? Anti-HBC. Which
IgM.
one? IgM. Yes, IgM. IgM. If you understand, I think this slide is over for you. Another addition only to say you that clinical illness, you see here line, it means the virus may be available in the blood before the clinical illness. So it is very theoretical, right? Patient will not come to us and I will not advise also. It is true, but natural course is as such. Fine. So these are the permutation combination, different stages of the hepatitis B virus infection, including the immunization status. Okay, immunization status here. All are negative, only antibody is positive. This is the immunization. Okay. Now a question to you. Dr. Ramesh, please. Please help me
A
to.
46-year-old
Yes.
A 46-year-old woman with chronic hepatitis C infection returns to you because she's losing weight. On examination, she's very thin. POC test.
Point of care test, what you can.
Point of care test.
Do you do or not?
RB, random blood sugar. I mean, sugar.
Blood sugar. Why? You are thinking random blood sugar important?
Because she's losing weight, she's very thin. So
you are thinking there might be high blood
hyperglycemia.
sugar? But if you are thinking they're very thin, type 1 diabetes in the 46-year age presentation, doctor, it will be earlier. Okay.
Yes.
So can anybody tell that? Don't think that POCT always available and we can do for each and every patient. May not be possible also. Okay. But rather chronic hepatitis C patient, maybe there is a chronic process is going on and patient developing something bad. Otherwise, why patient losing body weight? What could it be? In the chronic infective process, hepatitis C, patient becoming very thin. Dr. Javed.
LFTs?
Sir. LFT, point of care test may not be LFT. For the LFT, we have to send to the lab. So may not be urine analysis for what? Urine dipstick. How urine dipstick will help us in this background? Liver related anything?
Yes, sir, because to see urobilinogen,
that means the jaundice,
checking for the
patient. Jaundice patient. Yes. You can say the presence of the bilirubin, urobilinogen maybe. But chronic hepatitis is that much lazy disease. The breakdown is very minimum. Okay. And bilirubin may not be available in the urine. It's a very lazy disease, right? Very chronic. But what you are gazing, anything bad in this patient? Very bad?
Yes, sir. Hepatocellular carcinoma.
Could be. Now, you are planning this thing and you got the result like this. To check all viral markers, okay, including the follow-up test for what? This one, beta protein, alpha beta protein. Why alpha beta protein advised?
To exclude cancer. Carcinoma, yeah.
So, there is other investigation also needed to follow up the hepatocellular carcinoma. What is this? other than blood test by the imaging?
Ultrasound.
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 So as a lab test, very easy. For this reason, this is the first line investigation, and look at the investigation result. Anti-HBS is positive, but HBsAg negative. Okay, HBeAg negative, anti-HBeAg negative. So this is due to vaccination. Am I right?
Yes, sir.
Yes.
This is due to vaccination. But HCV, C virus is positive. So this is chronic hepatitis C, and alpha fetoprotein is maybe suggestive of malignancy. Why we are thinking malignancy? Because our patient presented with this not only by looking here. If patient is apparently healthy, alpha fetoprotein is high, we cannot tell this is underlying cancer. Our clinical feature telling that there may be underlying hepatocellular carcinoma. Then, sorry, this is explanation of this, the viral markers already we explained. Now, what will be the most likely diagnosis? Most likely means still we are not confirmed. Hepatocellular carcinoma on the top of chronic hepatitis C or cirrhosis of the liver like this. So hepatocellular carcinoma is the diagnosis here. So stepwise means we are discussing our patient first, then we are thinking that it may be routinely done because people are actually vaccinated. So for this reason, many vaccines are there. But if we don't go for this also, not bad. Only we will go for alpha fetoprotein. That's enough with ultrasound. That can give an idea also. These are additional viral marker. Okay. So your task in this patient now as OSCE candidate, who will summarize now? Other than this test, what will you do? Because you are suspecting it is an hepatocellular carcinoma. Definitely you will include one ultrasound of the liver. Isn't it?
Yes,
Plus, what other investigation will you include?
liver function.
Liver function, okay, you can say then.
Hepatitis C virus RNA level.
No, doctor already done, Dr. Javed. Anti-HCV is their antibody, okay, and it is already done, hepatitis C RNA. Otherwise, why they are telling chronic hepatitis C? It is initially done. No need to repeat. It will not give further value. Other test?
PT, APTT.
What TT, doctor?
Invasive test.
PT, APTT.
PET, APTT to see any coagulopathy there or not. Very right. Any other?
CT MRI
MRI, what message you are getting by CT or MRI?
for grading of
For
carcinoma.
bleeding, no. Carcinoma, yes. Imaging
Grading,
can
for
tell.
grading of carcinoma.
Yes. Ultrasound can give some idea. Even ultrasound may be normal also. If there is a small malignancy, CT MRI can help. Very right. Other? Why not a CBC,
HIV.
doctor?
HIV.
Co-infection
Yes.
HIV, yes. But why not CBC? A malignant patient usually will be anemic. Okay?
Definitely. CBC. Yes.
So for the management purpose also, so still I like to advise you the not only think for the diagnostic purpose. Always you are telling diagnostic, grading, malignancy, big as well, CT MRI, but you are not thinking that comorbidities also in the malignant patient. Patient might have anemia also, nutritional problem also. Even patient may need electrolyte, isn't it? Definitely patient need renal function test also to check the organs. But again, in the OSCE, I am telling to open up your eyes in a broader sense. But if you think that you will not treat the patient today here, remember, you will not treat the patient today here. So you don't need to grade the patient also by MRI CT, is not it? Doctor who said, female colleague,
Yes, sir.
right.
Right.
Though it is justified, rational, but you are a family physician. Now, I am telling you, you are examining, not physician doing your chamber. You are examining the OSCE and you are referring the case. So you don't need to do anything further also. Okay. You will talk that I am sending you to the liver clinic for further evaluation and management. At that time, for the explanation purpose, you have to say as OSCE candidate, they may do this. This is expected by the examiner in the OSCE exam. We discussed somewhere, possibly, maybe hopefully in the OSCE class. Those who are in the OSCE, keep your eyes in the group. For the management skill, we will, by the mercy of Almighty, arrange another session. Management skill. And these classes are definitely extraordinary, I like to say. Not very commonly available. So, for the management purpose, we will not do investigation. This is also approach. Unnecessary. Why we will do? I am not managing the patient and I am sending patient today. But any emergency for the vital sign or other, then we can do. Then we can do. So already this solved, right? Synthesis of the investigation. So regarding the tumor marker, our message is tumor marker advised for strengthening the diagnosis, but not for confirmation. I think all of you agree. As it is said, tumor marker is utilized for the monitoring. So it can be done in the later part after diagnosis. It is theoretically possible and it is justified, rational. But doctor, I like to say, and you also see that our consultant, even you also, advise the tumor marker earlier on the first day. The reason is that tumor marker very easy to be tested and it can give some indirect message that patient might have cancer. So it usually help us, but not for the confirmation of the malignancy. This is the message for you. Okay, so this is the discussion not needed now. Now the vaccination issue. After the vaccination, your investigation will be to check anti-HBs IgG. IgG. Again, tricks. Unfortunately, some colleagues are confused. You see anti-HBs written here, but they didn't write IgG. This is a tradition. Wherever immunoglobulin is not mentioned, think that this is IgG. Okay. And this is the range. What will you do? You will run from the book. Come to a next patient. Who will help me now by reading the patient today? Please, anyone?
An 84-year-old man comes for
Yes.
a review.
Please.
4 weeks
Okay.
ago, an opportunistic blood pressure reading was taken and recorded as 150/92. You therefore arranged ambulatory blood pressure monitoring along with a standard hypertension workup. The daytime average blood pressure reading was 145/80. You did not calculate his 10-year cardiovascular risk on account of his age.
This is a very, I think, prototype question for AKT. Those who attended our classes, you can remember. 84-year-old man, opportunistic. That means without any health problem, apparently you check the blood pressure and found it. What will you do? Will you do any point of care test now? This is my agenda today. These are the findings. Okay, observation. Point of care test. Any point of care test today?
Yes. As routine, we will check for a
Don't
blood
say
sugar
routine,
level.
don't say other. You just tell me the point of care test. Name what you can do now today. Dr.
Random
Ali.
blood sugar.
Uh,
Random
okay.
blood
Random
sugar.
blood sugar,
Oh,
yeah.
sorry. Dr. Ali, better to say capillary blood glucose.
Capillary globulin.
I think you understand what I am telling. So, because random
Okay.
blood sugar is a term utilized for the lab test, doctor.
Okay.
But in the chamber, point of care test will be capillary blood glucose. Better to say. Then,
Okay.
any other point of
Thank
care test? Any other point of care test? Can we do deep stick urine test?
Yes, sir.
Yes. Hypertensive patient, there may be nephropathy also, asymptomatic. Could be the reason of hypertension, maybe in the kidney. Proteinuria. Patient is apparently
Yes.
asymptomatic, right? And
Yes.
again, deep stick test, how it help us in such patient.
Protein level, yeah, definitely.
Not
Yes.
only, I already told protein, capillary blood sugar is there. Deep stick can tell about the sugar also, though we are not giving importance as capillary sugar done. Other result in the deep stick can help 84-year-old man. So protein
Yes, sir.
sugar, why not hematuria? Why not RBC? Hypertension can be cause of microscopic hematuria, yes. Okay. Can hypertension can be a presentation of the adult polycystic kidney disease, though it is an 84-year-old. Only hematuria is there. Yes. Maybe some asymptomatic findings could be present in the urine. So deep stick test will be very, very valuable test in such patients. So point of care test, this is one of the way. So my suggestion to OSCE candidate, please, in the even the last year also, we didn't give emphasis in our OSCE candidate to say in this way that you have to utter the word point of care test. But nowadays, point of care test took its position in our practice. If you start with these, your presentation will be very nice. That I will check in my chamber now, Mr. John, your blood sugar, it is a point of care test. Then after getting the result, I will send the blood for the lab test and I will send for the imaging and other. I think you can start nowadays from in this way. So after this point of care test, and you got point of care test normal, urine dipstick normal, what will be the next investigation plan? Dr. Ramesh, Dr. Ali, those who are interested, please
Yes, sir.
be enthusiastic. Be enthusiastic. What will be the next plan of such hypertensive patient?
Sir, urine for microalbuminuria.
Micro could be there. That means urine analysis including urine microalbuminuria. Okay.
Yes,
Then
sir.
That's usually for this
EGFR.
cardiovascular.
one by one,
EGFR.
one by one. Dr. Ali, please finish first. Then
EGFR.
EGFR. Okay.
HB1AC.
But before EGFR, Dr. Ali, why not serum creatinine? We are expecting that serum creatinine invariably will be abnormal. Dr. Ali?
Yes. Yes.
It invariably will be abnormal, serum creatinine? No.
May not be.
May not. If it is not, dipstick urine also normal, why we are advising or calculating EGFR? We can calculate EGFR anytime by serum creatinine, no problem. So rather serum creatinine and electrolyte. Okay? Then
Okay.
I think Dr.
ECG,
Ramesh can
sir.
ECG, yes, Dr. Ali,
Albumin
quickly.
creatinine ratio,
Albumin
ACR,
creatinine,
Yes,
albumin creatinine ratio could be there. Okay.
lipid
ECG also.
Yes, sir.
ECG,
Lipid profile, ECG,
yes, blood sugar. Blood sugar. If you
then a blood sugar.
if you don't have capillary blood glucose machine, so blood sugar in the lab. If I say your machine is there, but you don't have the blood sugar strip available. Okay, doctor. Again, I am making the story. Strip is available, but expiry date is over. Understand the reality? So what will you do? Again, you have to check the sugar in the lab. Okay? You cannot purchase the strip today also. It take 2-3 days. Adding some scenario, practical scenario. So you have to consider it. So lab test include common lab test, CBC and others also, right? Patient may be anemic. In hypertensive patient, there may be ischemia also to the heart. So many tests you can include. Again, I don't know for the academic question what they are planning. Many purpose we can utilize is, and actually I am not referring our patient today most likely. So I can cover many tests, including comorbidity, including cardiac risky disease, including complication, many other things. So it will be a total list for you. But commonly, it should not be forgotten. Electrolyte, creatinine, SGPT, lipid profile, sugar, and ECG. So these are the list of investigation in a patient of hypertension. We can include many other also. For example, if we suspect ADPKD, adult autosomal dominant polycystic kidney disease, in that case, what we will include here?
ultrasound.
Ultrasound. If we think it may be renal artery stenosis because you have gotten renal artery bruit, what next investigation you will include? Maybe MRI to see the renal vein.
CTN, yeah, MRI.
Renal artery, maybe the size of the renal artery, stenotic artery. But again, you are general physician, you are family physician. So if you don't have the capability to explain this to the patient or the message of MRI or other, okay, sometimes it is called, previously it is called the captopril, what is a renogram or like this to see the renal vessels. Dynamic dynamic ultrasound, it is called. But nowadays, MRI, CT scan possible. It can be included. But as a GP, for OSCE exam also, as a GP, if you don't include very extraordinary investigation, there will be no mistake. But if you don't include this thing, it will be mistake. Very common lab test available, very meaningful, more information you are collecting from there. So ECG can give us about the target organ damage. Urine RE also will be there. Okay, as dipstick normal, we are not including, but for the lab, we can include urinary for the microscopic examination by the what I say, the microscopist there. Okay, in general, we will include urinary also here or urine analysis. So you got this, the findings. Okay, including first degree heart block. Other findings are normal. Now the next question, what will you do now? Will you do further investigation or will you do any treatment or tell something to the patient? Dr. Ramesh?
Yes, sir. I will review him because the patient after 70 years, after 8 years old,
84.
we are not calculating. Yeah, we are not calculating 10-year cardiovascular
It
risk
is usually
assessment.
the scale is actually not designed for this age. Okay, it is advanced age. It is not useful for this age, 10-year vascular risk.
Yes.
So most appropriate course of action?
Is review him.
Come back after 1 month, 2 months, 3 months, 1 year, 5 year? Or take this medicine? Or now
no
AKT.
medication,
Wait,
doctor.
Dr.
Just,
Ramesh. My beloved AKT candidate, choose your answer from here. 5 options given to you. AKT candidate. Can anyone choose?
I think it's A. Diagnostic.
Diagnose stage generation, advice about lifestyle changes. And you are right. So before going to these decision making, we have to walk along this investigation, right? We have to check, is there any target organ damage? Is there any target organ damage happen?
No,
Dr. Javed? No. No. Renal function is okay. ECG is normal. First degree heart block is not related with the hypertension. It is a normal variant. Okay. If there is ST depression, okay, ST depression or LVH with a strain pattern, there may be the target organ damage in the heart. So diagnosis is enough today and advise about the lifestyle changes and tell the patient come back after 1 year or 2 years. Okay, so I think you now understood a very common disease of hypertension and this is the approach. Okay, we are not here. So already you have made the investigation list. So what is the tips we got? A combination of tests can be done if initial treatment is warranted. Even if you diagnose the hypertension, you will start with a calcium channel blocker or other. For this reason also, you have to do ECG, creatinine, electrolyte and other. So combination test, including the comorbidities and other target organ damage, sometime needed. Right. I don't know, am I taking too much time today? Some colleague may be leaving also. Maybe few minutes remaining as these are very common. So I am already slowing, progressing slowly in a slow mode because to let you understand. Now the diabetes, very again like hypertension, one of the common diseases in the world, and this is the bread and butter for the GP also. So Dr. Ramesh can help, please.
Yes, sir. A 52-year-old male with a history of dyslipidemia and hypertension attends the surgery for a 75-gram oral glucose tolerance test.
Yes.
As part of his cardiovascular risk assessment and screening for type 2 diabetes. He's overweight with BMI of 29, his blood pressure 135 or 85, and a combination of amlodipine and perindopril.
For POCT, what will you do as a POCT?
Urine dipstick first.
Dipstick for what?
For proteinuria, microalbuminuria.
Patient already attended for the OGTT. Okay.
And then the blood sugar. I mean, the capillary blood sugar.
No. POCT in the urine also justified. Urine, the most valuable test as POCT. Most valuable test. So try to identify something by urine dipstick for such patient. Protein?
Yes, sir.
Why protein you are
Protein level,
thinking?
protein.
Why you are thinking for protein?
Because
Hypertension.
he's
or that-
having a history of dyslipidemia, hypertension, chronic
Yes,
hypertension.
yes.
patient.
There may be renal damage due to hypertension. Very right, proteinuria. Any other POCD? Can we include
Capillary
POCD
blood
as
sugar.
can we include ECG as a POCD? ECG? Yes. If you have a ECG machine in your chamber, why
Yes.
not? Understand? So POCD is a very relative term. Which is available in your chamber, all investigations are POCD. No doubt. Dr. Javed, to include any other POCD? Yes, if sugar check is not intended here, we can include capillary blood sugar. But as patient attended for the blood sugar test to exclude diabetes, so capillary blood glucose not needed now. Possibly you have done earlier. Okay. So after this POCD, the next and the blood sugar, sorry, POCD may be normal or absent sugar there. And you got the result of OGTT as such. So we are now analyzing what is the correct interpretation of the result. What will be your glucose related diagnosis? OSCE candidate first.
Diabetes, because 10.4, 120.
So you label your patient, give a diagnosis in the point of sugar level in the blood.
Yeah.
It's type 2 diabetes.
The type 2 diabetes mellitus.
That means you already got the diagnostic value of the sugar.
Yes.
Okay.
Yes, sir. OGTT level is
AKT
second level is high.
AKT candidate option given for you. Choose now.
E,
And
type 2.
OSCE candidate also smiling now. What smiling
Type 2.
for? Is it type 2? E.
Yes.
Okay. Any AKT candidate to say something different? Dr. Javed, you also
Yes.
type 2. Dr. Ramesh, type 2.
Yes.
I will be very sorry to say.
No, sir, it's impaired glucose tolerance test.
Unfortunately, you become failed here, Dr. Javed. How easy question it is, but for the interpretation of the lab result, we are fallen here. Clear, Dr. Javed?
Yes. You have to check both. This means fasting as well as after 2
Yes,
hours.
a rule of 2. 2 tests should be crossing the diagnostic level. Otherwise, another possibility is there if patient having the typical symptom of diabetes plus any random level high or anyone is high. You see how AKT question designed? They made you foolish, rather to say. So this is the level, okay? I will not tell more. So 2 value should be, 2 sample should be, okay, with no symptom. Diagnosis require 2 confirmatory sample on separate occasions. Maybe fasting, or one fasting, another postprandial. Then you can say, otherwise only by the single test, not possible. So in this diabetic patient again, what will you do next? It is not diabetic, impaired glucose test. Will you do further investigation today? Yes. If it's dyslipidemic patient, if lipid follow-up needed, we will including liver function, renal function all together. So this again, this lipidemia is a common station in the OSCE. Those who have seen in the group, I'm sorry, anybody, I don't know, in the Chennai exam, I couldn't follow. In the last, maybe Friday exam was there. Anybody shared the case list? Please help us. In the last Friday OSCE case, I didn't pick up. Somehow I was also busy. If anyone, I'm requesting any, if present here, share your case list, maybe on the Friday exam in the Chennai. So you took the history from the patient. It's very common, dyslipidemia, hypertension. That is a metabolic syndrome case, maybe 2 cases also in different angle. Each session of the OSCE. So these are very important topic or subject for the AKT. So how will you design your investigation? This is up to you now. But Patient preparation is very important, because how can you make the patient fasting? You must know it. So patient preparation is important as a GP. Otherwise, your result will be in wrong. So fasting blood sugar or GT test, this is the preparation technique. You must follow it. Okay. But if you cannot utilize this information 100%, we have to consider this thing that something could not be done. We have to analyze the patient and a patient's result. If it is a very high, too much high, okay, and you couldn't prepare the patient 100%, even then we can diagnose the case. Okay. So how to make oral glucose tolerance? Rest for the 30 minutes, other. Practically, it is very difficult to arrange. Okay. And advise the patient not to take some food before the test. This thing, extra sugary foods and other thing as usual. And fasting will be 8 hour to 12 hour. Okay. And the preparation for the fasting for the sugar test 8 to 12 hour, but for the lipid test 9 to 12 hour. Now my question to all of you. You patient have diabetes and you patient have dyslipidemia. So you are advising sugar test as well as lipid test. How many hour fasting she is to follow or he is to follow? Patient will come tomorrow morning. What will you tell? How many hour fasting is justified for the sugar check as well as lipid profile check? Minimum
10 hours?
9 hour.
9 hours.
9 hours.
You see, 9 can cover the lipid, 9 can cover the sugar. So we have to say minimum 9 hour. Okay. It may be 10 hour justified, 12 hour also justified, but only sugar is 8 hour justified, but as lipid is there. So this is the way of advising the patient as a part of the patient preparation. This is another diagnostic test for the pregnant lady. This is different value we must follow. We have to go for the 3 check. 3 check means fasting 1 hour after and 2 hour after glucose drink. And the value also different. Remember it for the pregnant lady. Maybe we are near the end. Just be with us few minutes. One report given to me in this way. Very interesting. And I marked here, it is not printed. Actually, it is true. It is not printed. No printing mistake is there. What is the reason? Possible reason?
Maybe sugar diabetes for less than 2 months?
Less
That's
than 2 months. So there should have some A1C level.
No, it is most confirmatory
Sorry,
with 3
Dr.
months.
Asma. If less than 2 months, the A1C will not give us message. It is true.
Yeah.
It is true.
Yes.
But here A1 could not be detected also.
Mhm. Okay, maybe due to some hemoglobinopathies, the result is
Fantastic.
false.
Fantastic. What hemoglobinopathy?
Like sickle cell anemia in pregnancy.
Very right. Thank you, doctor. You got 10 over 10.
Thank you.
100%. 100%. Okay. So this is the answer. And below what is that lab expert also given this. The patient might have abnormal hemoglobin. Very intelligent technician and or whatever the expert. They said A1C result is not reported. The A1C may not be there also. Or some defective hemoglobin, machine couldn't read it. May I ask another question from the same report? Not for the hemoglobin, but for the cholesterol level. And I faced in my postgraduate exam, I can remember for life. That is the report showing LDL not given like this. Okay. And the cholesterol is 220. Okay. Triglyceride was maybe 700 or 800 like this. HDL as such, but LDL not given. What is the reason? Again, it is a printing mistake. As it is very common test, my beloved colleague, try to learn it. Dr. Ramis?
Non-fasting.
No, it is a fasting. Simple is fasting. But LDL not mentioned. The reason is that usually most of the lab calculate LDL level from the triglyceride and other values. But when triglyceride is too much high, LDL level is not representative. Okay? Only maybe 300, 350 TG level, LDL level may be correct. So be careful about this. For this reason also, advise the patient for fasting lipid profile, because postprandial lipid profile show unusually high triglyceride. In this unusually high triglyceride can give wrong result of LDL level. If it is separate reagent is not utilized for the LDL, but most of the lab don't use separate reagent because it may again include the cost. Clear, Dr. Ramesh, and all for all of you.
Yes.
Actually, my intention to show you the hemoglobin A1C, but by chance I told you about the LDL. Remember it, doctor. Okay. In the endocrine test, first test will be the biochemical test, then go for the imaging. This is the way. Otherwise, imaging target will be missed. Localize the disease by biochemical test. Where is the disease? It is in the pituitary gland or adrenal gland. Then advise for the MRI for the adrenal gland, MRI for the pituitary gland. Simply this is the message from here. And actually we are at the end today and very grateful for your patient hearing. Now I don't know how much I was able to let you know investigation, understanding, brainstorming. And if you don't have any question, we can conclude. And this is that the list 18 principle till now we have discovered as investigation principle. Some of principle we explained today, and remaining principle also to be discussed, but not in a regular session like this. And we are hoping to organize a workshop for extensive investigation. It may take many sessions. Just keep us in your prayer so that we can do for you in course of our discussion class, not only for the exam. Definitely will be useful for AKT or OSCE, but in our day-to-day practice. As you are joining with us, we are very happy. So we will try our best to explain you 18 principle in workshop in future. Keep your eyes in the group. But for this thing, again, another important, not only for investigation interpretation, rather getting the abnormal result of the investigation, what will be the follow-up plan? It is not universal. Test to test result will guide us to say the patient come back after 1 month, come back after 1 week also. So this is also our plan. We will try our best to collect the information. It is not ready-made everywhere till now. So I will try my best for my reason also, and I will try my best to share with you. After normal test, sporadically many that normal sugar today, then when will you check again sugar like this? But high sugar today, when will you check again sugar today? Sugar after how many days? Creatinine abnormal today, again how many days later you will repeat the creatinine test? Likewise, we will try our best to gather the information and we'll share with you. And investigation, that is our plan. Investigation workshop rather to say for you. Okay, I will be very happy if I can do by the mercy of Almighty. Again, request. See you again in another class.
Thank you.
Assalam
Thank you so much.
alaikum. Assalam.